Well, we're so privileged to have with us Dr. Neil Schecter, who is an international force in pediatric pain and who has been at the pinnacle and in the stratosphere of organized efforts on behalf of pain and pediatric pain for at least 2 decades. And I think I met Neil originally a couple of decades ago in connection with the U.S. federal guidelines on pain control. And we've also had some other neat experiences in weird parts of the world, interesting experiences, etc. But without dwelling on them, let me shift to why we are so happy that Neil is here today lecturing on behalf of our Pain Research, Education, and Policy program. Neil has spearheaded a program which is a unique program, which has gotten tremendous recognition and support from the most prestigious of organizations, and that lies at the interface of public health, including human rights, and the movement to improve pain control around the world. Many of you know that the Institute of Medicine in the US came out with a report this past summer, in June of 2011, which firmly asserts and provides a great deal of evidence in support of the problem of pain being a public health problem and the effective approaches being framed as population-based approaches. So this actual conception is not new to Tufts. By the way, my name is Dan Carr, and I'm trained in biomedical science and anesthesiology and medicine. Co-founded the program a dozen years ago with a PhD medical sociologist, Kathy Lash, who now has gone on and works in industry as director of patient-reported outcomes for an international outcomes research company. So our program from the outset, initially under Harris Berman and more recently under Aviva Must, has been firmly located in a Department of Public Health and Community Medicine. So I cannot emphasize enough how fortunate we feel to be located in a setting where the people got it, the leaders have got it and continue to get it. So having said that, I'm going to turn the floor over to Neil, who will emphasize his work in pediatric and public health matters, and particularly the program called Childkind. So thank you very much, Neil, and we'll give you a warm welcome.
We are now. Is this working now? I have all kinds of buttons and wires here. I feel a little bit, I couldn't go through an airport right now. Anyway, well, thank you very much. It's really a pleasure to be here and to speak to this group, and thank you for taking time this afternoon out of everybody's busy schedules and at the end of the day. Oh, I'm supposed to, can everybody hear me back there? Great, great. Thank you again. So, thank you, Dan, for that generous introduction. And again, I hope people here realize what a national treasure Dan is, actually, the work he's done. We've been together on a number of projects, and he's been a leader in this field for a number of years. And so it's a pleasure to sort of be back in Boston, where I was a number of years ago, and only have recently returned, and to be able to collaborate with him. So I'm at Children's Hospital now, and have been toiling in the vineyards of pediatric pain for a very long time already. And what I want to do today is to give you a little bit of the history of where we've come from in the world of pediatric pain and where we are now, and then a little bit about how we can perhaps change practice, because as I'm implying to you right now, there's still some ways to go down the road to get to where we want to be with this. And then I want to emphasize in particular some other concepts that have emerged around not so much pediatric pain, but pain in general and in other areas, how we can change practice behavior more effectively. And that's through kind of a broader institutional-based commitment to some of these issues. So we're going to talk about all those things over the next hour or so. Keep forgetting which is forward. Okay. So where are we going with pediatric pain? Well, this started, I would suggest to you that the world of pediatric pain is about at least 10 to 15 years behind where the adult medicine world was, at least from the beginning. It took us quite a while to sort of get going, and there's a whole bunch of reasons for that. But the first notion, when you start to read about pediatric pain, the first notion of it came out in medicine clinics of North America, and adult medicine clinics, that talked about the pediatric intensive care unit, and that was by somebody named Swafford, somewhere in the late 60s. And the statement was in that basically you don't have to worry about pediatric pain because children really don't experience pain. And they suggested that based on some of their neurological data that suggested that children weren't fully myelinized by until somewhat later in life. And therefore, really, it wasn't really worth worrying about, and they could be crying for lots of different reasons. And that was sort of good to think that way because we didn't really know anything how to help anyway, so it would be better to think that there was really nothing going on there that we'd have to intervene at. Joan Eland, who was a nurse at the University of Iowa's hospitals in the mid-70s, was sort of the next step in this chain. And what she did in the 70s was think that maybe that wasn't so accurate, that maybe kids felt some pain. And she then did what we would consider an unpublishable study now, but which sort of started the ball rolling here. And she walked around the floors at the University of Iowa hospitals and took 25 charts, seemingly random but not really random, just charts of kids who were there getting one sort of surgery or another. Neck mass excisions, a whole host of other myototomies, nephrectomies, palate repairs, a whole bunch of traumatic amputations. And she, at those 25 charts, looked at the kind of analgesia that kids were receiving at that period. And what she found was, it's going to sound relatively shocking to those of you who haven't been through this, but that in total, through their hospital stay, those 25 kids received 24 doses of analgesia. In total. 12 of them received nothing at all. And of the ones who did receive them, some received a little bit of acetaminophen, some received some opioid. But there was just no comfort level in that era with analgesia or even anesthesia, as we'll talk about in a minute. So they basically received very, very little in the way of any sort of pain relief. By the mid-'80s, a number of people have started to look at this. And in general, the suggestion was, by that time, looking at adult and child dosing, that there was really significant disparities. We did a study during that period at 4 different hospitals around the state of Connecticut, where I was at that time, a university hospital, as well as some rural hospitals, urban hospitals, different types of settings, and found in general that the kids received, for the same, as compared to the same illnesses for adults, or the same disease processes or surgeries, the kids received about 1/4 of the number of doses per hospital day that the adults did with the same exact problems. We looked at fractures and appendectomies and burns, 20% body burns, a number of things that we looked at, and there was a clear disparity in the way that kids and adults were handled. And when Mather and Mackey and other groups, they looked at postoperative cardiac cases, they found in general that there was, again, this massive disparity in lots of different arenas. And the other thing that occurred then is that almost all doses were ordered PRN in that period, meaning don't do it, basically. As little as possible, it was interpreted for the most part. So in general, there was extreme undertreatment, we would suggest, in that period of time. Okay. So that's kind of in general. Well, it was even in specific situations, it was even more extreme. The newborn, the word infant comes from enfants, which means basically voiceless. And kids were voiceless during this period, certainly. Depending on the discipline, we did a study like in the late 80s or something like that, looking at attitudes around pediatric pain, and found that 20% of practitioners didn't think that babies felt pain during that period of time. So that explains some of the practice behavior, which was in particular the kind of rather noxious practice of not using anesthesia for babies. And perhaps a number of you are familiar with that. We would basically, during that period of time, especially for things like ductal ligations, basically just paralyze the kids with curare. And so their sensorium was unaltered, and then do the surgery. And that was a standard of care, and it was a standard of care for good reason. We needed to do the surgery. We didn't know what else to do at that particular time. There weren't other adequate studies and they'd rather save the baby's life than risk the baby's life, if you will, with drugs that we didn't know their ultimate impact. Sunny Anand, who some of you may know, who was at that time at Oxford getting his doctorate, he had gotten an MD before that, for his PhD thesis, looked at babies in the newborn nursery receiving ductal ligations, and by that time they were using some anesthetic in some subset of babies. And so they randomized babies to those who got, I believe it was a halothane anesthetic at that particular time, versus babies who got nothing. And there was this massive outpouring of stress-related hormones in the babies who got nothing, along with a much worse outcome. And so ultimately that study that he published in Lancet initially and then in a number of other journals provoked a dramatic change in practice. And there were editorials, 9 editorials I counted within a year after that study that suggested that this is a barbaric practice and that if we don't know how to use these drugs, we shouldn't be in the business of doing this kind of surgery. And practice changed pretty dramatically. But anyway, that was how things were then. Procedure pain, and for those of you who are in the pediatric world and who worked in neonatal intensive care units in that era know we were sticking needles into babies at the drop of a hat, doing LPs without chest tube insertions, all kinds of stuff. It was just the way it was done. And again, we didn't know what else to do. There weren't other strategies. We didn't really recognize that there might be long-term negative outcomes as a result of that. So that was sort of the standard of care. There was even a study as recently, though, as about 3 years ago by Carbajal from Paris, who looked at number of procedures done on anesthetizing babies in the Paris NICUs. He looked at 25 NICUs around Paris. And even now, there's still a significant disparity amongst the way people address these kinds of problems. But anyway, the classic study of this was in the mid-90s when Barker and Rutter looked at 54 newborns in one of the nurseries in England, and they found in total 3,000 procedures taking place, none of them with any local anesthetic. Okay. Procedure pain was another kind of source of distress. And again, the typical scenario at that period was that parents were exiled from the room or from the ED, and we would sew up the kids without really any anesthetic at all. That was just a standard that we did. We didn't really know what else to do. The kid had a laceration. We had to repair it. Bone marrow aspirations, bone marrow biopsies were done with local anesthetic sometimes, but not even with local anesthetic in some settings. And this was the typical sedation that we used. You know, babies of all mini, maxi, what is it, grande, vente, whatever, different size papooses for kids that when we had to restrain them because we had to do the procedure and we didn't really know what else to do. So in general, 25 years ago, when some of us started in this field, there was basically no formal research on pediatric pain. We didn't know really how to assess pain in kids. There was really no data on drugs because kids were a small market and there was limited financial incentive for the pharmaceutical industry to go ahead. We had no concept of the long-term impact of pain, but we did know that some of the drugs could hurt people. So there was a real tendency to undertreat and be therapeutic nihilists. Postoperative pain was typically an afterthought, and newborn pain and procedure pain were almost essentially totally ignored. Well, why was this so? I mean, everybody who was doing this kind of work were nice people. We liked kids. We weren't there to hurt them. That wasn't anybody's goal. But there were a number of complexities that made it very difficult to do pediatric pain work. First of all, there was the difficulty of assessment in kids. And as you all know, now with JCO, it's sort of common practice demanding that people be asked about their pain. And that's fine if you're over the age of 8. But under the age of 8, it's a little more complicated. And so kids over the age of 4 or so can seriate. They can quantify things in a certain sort of way, but not necessarily numerically. They can do it in an order. So it took quite a while, and the newborn babies obviously are not going to tell you about their discomfort. So it took quite a while to develop, and that's not the topic of this talk. We could talk for hours about a pain assessment in kids and the developments that led to that and how we figured some of that stuff out. Some of the most interesting work came out of the work out of the FBI that looked at lying, that faces that were associated by a guy named Ekman who looked at faces, the lying face, and they extended that facial coding action or facial action coding systems to newborns. And some of the earliest work came out of sort of videotaping babies and looking at their face and particular aspects of their face, nasolabial flattening, brow bulge, taut tongue, a variety of characteristics that were associated with it. So anyway, that was a real problem, and that really prohibited a lot of advanced work in this. There were ethical constraints as well, because kids couldn't really give consent in a certain sort of way to be randomized, and and there was certainly a lack of financial incentives on the part of the pharmaceutical industry, as I suggested to you. There was really not a lot of kids taking morphine on a regular basis. It was a drug that they were only going to take for a short period of time anyway, during that era anyway. And so as a result of that, there was just no incentive, no drive. It was very hard to find any pharmaceutical company that would support any kind of research in this arena. And when we did that research, still as a problem now, it's against placebo typically, as opposed to against another drugs. So we're still kind of stuck in certain sorts of ways about knowing how best to approach some of these, but we'll talk about that in a little bit. And then there were a number of, that lack of research allowed a number of myths to be perpetuated. The main one was that, of course, that kids didn't feel pain. This is a classic New Yorker cartoon. Says, no, they're not like us, they don't feel pain. And that was really the conceptual framework, that because of neurodevelopment, a lot of studies suggested that really kids didn't feel pain. But there were other myths as well, that kids who were sitting quietly weren't experiencing pain because if they could play, they weren't really in pain. A whole host of other things that we now know to be incorrect. Okay. So over those years, a lot of work has been done. And there was a letter to the editor of the New England Journal in the mid-'80s, or I guess mid to late 80s, 87 I think it was, that looked at the pediatric textbooks and the number of pages about pain management that were present. And they found out of 24,000 of pages of textbook, of which 10 major textbooks, they found a page and a half. And in certain areas like sickle cell disease, a bunch of other things, there was basically nothing in the texts about them. Most of those were on functional pain problems. So really there was very, very little information available. So there has been an outpouring of work, a lot of it animal work, a lot of it other clinical work, that has helped us understand pretty well the developmental neurobiology of pain. We also came to recognize, and a lot of this was with the animal work, and Sunny Anand's work started some of this, that there are clearly consequences that occur as a result of long and short-term impact of inadequately treated pain. And there's lots of them. Sunny Anand's work, as I suggested to you, suggested that there was a very significant outpouring of stress hormones and a worse clinical outcome amongst kids who undergo surgery without anesthesia. Mariah Fitzgerald, who's the person in the field at the University College in London, has done lots of work with animals looking at the development of central sensitization and a whole host of other things, identifying the fact that there are long-term consequences to babies when newborn rats, for example, who are at particular phases that they use, are subjected to a whole host of traumatic experiences. There's a significant difference in the way they experience pain downstream. Anna Taddeo looked at circumcision work and found babies circumcised without anesthesia had a slightly different response later on to painful stimuli. And we did some work as well, and I just want to explain some of this work to you. We took advantage of the kind of natural experiment because in the period when we were doing this work, we were doing work with what was then called a fentanyl lollipop. Basically, it was a transmucosal fentanyl, and we hoped to use that for sedation for kids in the ED. We thought that would be really a helpful drug for us. Turned out to be not so great, but that was our thinking. And anyway, we started out looking at bone marrow aspirations in kids, and some of the kids were randomized to either receive just local anesthetic or fentanyl, and that was the standard of care at that time, the fentanyl lollipop at that time. And this, on this side, is what was then called the Oucher, which is one of the early pediatric pain scales. And so these are the Oucher scores, and this is the number of procedures that kids experienced. And what we found was, in the study, the fentanyl helped put them to sleep or made them somewhat sedated. They were more comfortable. And the kids who received transmucosal fentanyl reported lower pain than the kids who didn't. But then all these kids had cancer, and they all required multiple bone marrow aspirations in the future. For all bone marrow aspirations after the first one, we used the appropriate dose of fentanyl for those kids. Yet, as you can see, the kids who had the initial negative experience for all bone marrow aspirations subsequent to that reported more pain than the kids who had a positive experience initially. In other words, there was a set point change, a perception that this is going to hurt, and because of the impact of perception and cognition on pain, it did hurt them more. And so they all reported more out till we looked as far as 4 bone marrow aspirations subsequently. So that, all that kind of work, the animal work, the work on newborn anesthesia, this sort of work, there's also work that Ruth Grunow did on follow-up of babies in the NICU. That combination of work really changed significantly practice patterns, I would say. So over time then, we have developed a really good understanding of the safety and efficacy and dose response, pharmacogenetics or pharmacogenomics, and clinical outcomes of analgesics and anesthetics in kids. So we know a lot more about the drugs. We know a lot more about the sort of multifactorial nature of pain and the multidisciplinary pain services that emerged in pediatrics and in adult medicine really helped our understanding of how to treat these problems. There has been the development of a very sophisticated psychological research base in this arena as well. So it's almost stronger than a lot of the other pharmacologic work in terms of the impact of cognitive behavioral therapies and other types of interventions for pain. And so we basically have, for the most part, the ability to assess and treat the overwhelming majority of pain problems in children, regardless of their age and regardless of their cognitive capacity. Yet, when we start to look at where we are right now, there's a bit of a disparity between what we can do and what we actually do. This is a little bit older, but there are multiple studies that have come out since then. And most of these studies suggest that, in general, about 20% of kids in hospital experience significant pain at a given time. There's a famous study at the university at sick kids in Toronto, and they took all the kids during one day and went from room to room to room to find out their level of discomfort. And across the board, I'd say some of the post-operative kids were better than the medical kids because they were more predictable pain. But in general, 20-25% of kids were uncomfortable. Same work is done in Sweden and in the UK, and obviously in developing countries, low and middle income countries, those have even more of a disparity. This is some work from Alan Finley, who's a colleague of mine, and he's doing some work with our project in Thailand, and they found there a very large number of kids were experiencing what we would consider perhaps unnecessary pain. Likewise, for hospitalized kids, this is Euphemia Jacobs' work, she went around to different units within the hospital and found that with similar sorts of problems in different units, there was a real disparity in how these problems were handled. Likewise, or not likewise, but in addition, a study that's been very meaningful to me and to some of our work is by someone named Amendorp. And what that individual did was survey 300 parents of kids in hospital. And they asked them 2 questions. One was, what is important to you during this hospitalization? What's the most important thing? What's your highest priority within this hospitalization? And number 1 was, of course, treating the problem, figuring it out and treating it. Number 2 was that their kid was comfortable during the hospital stay, that their pain was adequately managed. And then they asked them about how satisfied they were with their hospital stay, looking at similar sorts of things. And the greatest disparity between priority and satisfaction was in the area of pain management. Again, this isn't all children's hospitals. Newborn pain, likewise, that was sort of in general, but in newborn pain there's been a dramatic change in attitude. If you ask anybody working in NICU now, they will say kids have pain. Yet, when we start to look at, in a sophisticated way, at what people are doing, this is some work of Deborah Harrison in Australia, and they went to all of the NICUs. They were able to go to all of the NICUs in Australia and find out who had policies around pain management, what exactly they were doing. And even though individuals were doing an excellent job in terms of looking at policy and procedures, most of them didn't have any specific policies, and there was an enormous variability on what people actually did. I already alluded to the Carbajal study. And in another study that came out not too long ago, they went around a particular city and looked at opioid prescribing in a large city and found 28, in one NICU, children were 28 more times likely to receive analgesia for one problem than in another neighboring NICU. Okay. Procedure pain, there's been, again, a very dramatic improvement in this arena. any children's hospital that you go to right now, if you go into the ED and you have a laceration, more than likely there'll be adequate sedation applied for that. It's not that sort of papoosum anymore. Yet there still remains a disparity, and there's still a lot of choices that people make, and there's still a lot of research to be done, I would suggest to you, about the best methods of sedation that vary from place to place, about needle pain in particular, which again is something that we're not going to address today, but is a critical arena. So there's still work to be done in that area as well. So in general, if I had to sort of summarize where we are now after 25 years of very active investigation and clinical practice in these arenas, there's an enormous increase on pain in children. There's a lot, 3,000 to 4,000 articles come out a year, as opposed to basically nothing not too long ago. There's been a dramatic change in attitude and a significant improvement in clinical care. Yet, inter- and intra-institutional variability still persists. There's a smaller but significant number who perhaps experience unnecessary pain. And for countries that are what we would call low and middle income, there's an enormous, enormous gap in terms of the quality of what we know and what they can do. Okay. So what are some of the barriers to changing practice? Well, I just suggest two to you, and I'm really going to emphasize the second one. But there are still remaining some gaps in our knowledge. Hey, Maureen. The length of persistence of changes in the nervous system in newborns following procedures, we don't really have a good feel. We also don't have a good feel for the impact of opioids in newborns that we've started using in very significant quantities since there's this change in policy and practice. We continue to lack adequate biomarkers, and there's a lot of research going on in that arena. We don't know if there's a difference in the nervous systems of individuals who develop chronic pain from those who don't. Somebody would twist their ankle and get CRPS, and they suffer, and somebody has the same ankle injury, and they don't have any problem. What's the difference in those populations? We have a real need for head-to-head comparisons of analgesics and co-analgesics to develop best practices. As a matter of fact, there's a group forming with a little bit of seed money called PRN, which is looking at an attempt to do what we did for oncology, to have a group of institutions that can, again, do head-to-head trials of analgesics, because the pharmaceutical industry is not going to support the type of trials that we want. And that's actually in the process of emerging, literally as we speak. It's a conference call tomorrow on that. There remains limited research on polypharmacy and psychotropic medications. We need more sophisticated data on physical therapy, which everyone suggests is critical for chronic pain, yet we really don't know. 2 times a week, 3 times a week, 5 times a week have enormous implications financially. What procedures, what desensitization, that research is really lacking. We need some better research on psychological strategies, although as I implied to you, that's some of the areas of best research, in particular in the chronic pain arena. And we need some new paradigms for chronic pain to understand better what happens, as well as new models of care. But, having said all of that, we do know an awful lot. We have learned a tremendous amount. And what most people in this field feel is that if we would apply what we know uniformly and routinely, that we could dramatically impact practice behavior. And this is basically just says what I just said to you. And this is a quote, amazingly enough, from a person who was very prescient and clairvoyant, John Bonica, who is sort of one of the founders of the field of pain. And he wrote in his 1990 textbook, "For nearly 30 years, I've studied the reasons for inadequate management of postoperative pain, and they remain the same. Inadequate or improper application of available information and therapies is certainly the most important reason for inadequate postoperative pain relief." So it's really we know what to do. It's a matter of doing it uniformly. And that's what I'm going to spend the rest of my time talking about. So one way of saying that is Goethe's quote, "Knowing is not enough." That's the title we must apply. "Willing is not enough. We must do." And this is a visual representation of that. People taking an escalator up to a fitness center where just because you know something doesn't mean you're going to really do it. And this is from my favorite website, despair.com, which is because people are really frightened of change. This says, "Change, when the winds of change blow hard enough, the most trivial of things can turn into deadly projectiles." And that's what we're afraid of because change is frightening for all of us. So there are traditional methods of sort of evoking change in institutions, and I just want to sort of go through them, and you're all familiar with this already, but I sort of want to just run through quickly how inadequate they presently are, and then sort of move on to some others. So we're going to talk a little bit about education, about guidelines, and about quality improvement. So everybody here is familiar with continuing medical education and undergraduate medical education, and there we're talking about sort of what's considered passive medical education, which is basically this, sort of, but sitting in an arena with a relatively random talk, and conferences and rounds just in general. And then there's active research, active education, and the literature would suggest pretty overwhelmingly that that is far better, and that is sort of either for those of you who work in offices, office-based outreach, small group instruction, case conferences, and then education and consumers. And I'm going to talk about each of these things just a little bit. So the data over and over and over and over again suggest that for grand rounds lectures and just standard CME, that the impact of sporadic lectures on behavior and practice behavior is somewhat limited. Obviously, it's improved somewhat if it's an area of specific interest or you've had a recent case and can apply it that way. But in general, all the Cochrane database suggests when you look at it that sort of the standard lectures that are a cornerstone of how we do medical education are somewhat less effective than we like to think they are. This is a famous study from about 10 or 15 years ago that Linda Frank did, and she went to, got 128 nurses from Holland. This was in Holland when she was in Amsterdam. She was working at the Children's Hospital there. And she wanted to teach them about pain assessment. This is when we finally knew something about pain assessment. And somehow was able to get enough grant money or support or whatever to free them up for 3-hour weekly classes for 8 weeks. 24 hours of education around pain assessment. Incredible to even think that we could allow someone to have that level of increased education, but it happened then. She found at the end of that there was no perceptible difference in nursing practice. And again, the reason for that, and trying to explore the reason for that, it was because the nurses felt in that period that their documentation was essentially useless. It was paperwork. No one was really responding in one way. There were no protocols within institutions that would suggest the next level. If they'd say somebody had an 8 or a 9, they were still at the mercy of a clinician to prescribe medication. And as a result of that, very rapidly, there was a decrement of the knowledge that they had acquired in that course, because it was not so useful. There is some literature that suggests that active medical education, and that's what I think a lot of us do, rounds on the floor, case-based discussion, small group instruction, seem to make a difference. We did some research in a particular area of active education, which is called educational outreach. And it's less applicable, I'd say, for a hospital-based setting, but certainly for practices it makes some sense. And the Cochrane report suggests that educational outreach is probably one of the most effective educational strategies, and most effective, of course, for those people who are working in office-based settings. And the idea is that basically we stole it from the pharmaceutical industry. You go there, you put on a tie if you're a male, or a nice suit if you're a woman. You bring bagels or danishes or something like that. You go in there, you drop very attractive material off, and you theoretically make the case why your new drug is the thing that they should be using. It's labor-intensive and expensive to do, but again, the pharmaceutical industry has obviously felt that it has value. So there have been a number of places, Jerry Avorn and a number of people at the Harvard School of Public Health, other people have developed similar strategies by nonprofits to go to offices. And we decided to look at injection pain and see if we could influence that practice. This is called Before the Shot, and this is a famous Rockwell painting where that little kiddo is studying the doctor's credentials as he draws up the hypodermic needle. So we decided to look at immunization pain, and immunizations are a huge source of distress in kids. As any of you who are in practice and with young kids know, or have young kids, know that we've dramatically increased the number of injections that occur at a given time, and at the 2-month visit there can be up to 5 injections. Very devastating for parents. There's good data that providers don't like to do that, and they find excuses not to give the full complement because the trauma that they feel that they're inflicting. And there's a lot of research about how we can do it better, yet for the most part, studies suggest that we're still giving injections the same way we did 50 years ago. So we decided to do a project around academic detailing or educational outreach to look at injection pain. We went to a bunch of offices. I'm not going to spend a lot of time in this. We had an algorithm of things that seemed to make the most sense of what we now know. Some of that involved some attractive brochures to give to families. It definitely involved food and finding a time of day when we could get in there. And the bottom line was we were able to, with an intervention like this, just an hour or two visiting the office, look at patient responses 6 months later and found that a lot of the suggestions we made were adopted by practices. So that's something that has some feasibility in certain settings, but again, not going to be the mainstay of how we create practice change. Consumer education is certainly one thing that also influences practice. Parents are becoming increasingly effective advocates for their kids. They're demanding certain sorts of things. They're going to be attracted to settings in which that are known to provide adequate comfort as opposed to those that might not be. And there's lots of ways to do that. I'll talk about some of the ways we did in Connecticut when I was there, which had to do with signage throughout the hospital, a pledge to families, brochures, information in offices, in advance articles and lay publications. All of that can sort of change in some way physician and nursing practice behavior. So in summary, in terms of educational strategies that we have available to us, we now know that sort of traditional methods are not so effective. And the literature would suggest that if we layer in consumer education, active education to some of the things, a multimodal or multifaceted approach, that there's a much better chance that practice behavior will in fact change. But I want to emphasize that education is only a limited part of how we can create overall institutional change. So what about guidelines? So Dan ran the Agency for Healthcare Policy Research, Healthcare Policy and Research, AHCP. Yeah, well, anyway, we all went to these meetings a couple of times over 2 years. He wrote this summarized this brilliant policy, and it was basically condensing available evidence. We gave it out all over the place. 100,000 of them were requested. It was very popular. I've been on the World Health Organization where we developed cancer pain guidelines. There have been many, many agencies and organizations and nonprofits have developed these kind of things. When one looks, however, at the impact of guideline development on practice change, it's hard to identify it. It's hard to identify it. And this was a paper in 2000 I think it was in JAMA that looked at why don't guidelines change practice. There have been a number of other studies that have looked at that. Well, why don't they change practice? Well, it's hard to know, but people surmise that people perceive that the guidelines make undue demands on clinicians, that they're done by people in ivory towers who don't have really relevance to their own practice, that particular person, that they'll be expensive to implement, that they have a lack of relevance to their particular situation. The people who made that don't really understand our situation. So in general, people have found that if you take guidelines and adapt them to specific institutions and specific logistics of specific institutions, we do an awful lot better. But again, guidelines themselves, which we thought really were going to be, people would grab onto them and everything would be fine, really didn't turn out exactly the way we'd hoped. What about quality improvement? Again, there's a fair amount of research on audit and feedback and the impact of that on behavior. And again, I would say, when you look at the Cochrane database and some other things that have looked at this, it's moderately successful at producing some change in specific behaviors. People who've looked at why that doesn't work suggest that there's no chance to use the feedback that you get immediately sometimes, and that's potentially problematic, and often no penalty for not responding to feedback. One of the classic quality improvement measures that we use are patient satisfaction, and we know that those are ridiculous in terms of a measure of adequacy of our programming, because there have been lots of studies. Chris Miaskowski, a bunch of other people have looked particularly in the area of pain, they looked at people who were out of the hospital when they were sending back their, what are they called? Satisfaction. There's a bunch of them, the Picker surveys and the Press-Ganey surveys, and they'd look at those surveys and they'd call families in particular, and everybody was very satisfied. And then they looked at their pain scores in the hospital, and they had moderate to severe pain for a huge percentage of their time in the hospital. But people were happy to be alive. They were happy to be out of there. Whatever was done to them, and they're okay now, and the procedure was completed. So patient satisfaction, which is something we rely on very significantly, turns out to be a less than ideal measure of way to instrument change. Okay. This is one I think that's pretty interesting. This is the American Pain Society's revised guidelines for, it's all for adults. But what they've done is go to patients specifically while in the hospital. And they demand that survey. And they ask, indicate the least pain you've had, the worst pain you've had, and they looked at a bunch of functional indicators, how well you can stay asleep or fall asleep, what are you doing in the hospital, are you walking around? So they looked at functional indicators as well as people's overall sense of satisfaction. They've also asked them sort of what sort of strategies were used, so we have a more accurate indication of what people were doing. I think this type of work will help with quality. It's brand new. It was published in December, and it's only been used in a couple of settings, but it seems that it might have a little more impact than some of the other ones that we've used traditionally. Okay. So then a lot of people said, well, let's lump a couple of these things together, because I think maybe that'll be the way that we can change practice. So the American Alliance for Cancer Pain Initiatives, which is now state pain initiatives, sort of morphed as a group, but they published a paper a couple of years ago in the Journal of Pain and Symptom Management, and they did 113 healthcare facilities, and they had an active educational program, and as well as an ongoing quality improvement program. And they found moderate improvement, but still a huge percentage of patients, a significant percentage of patients rated their pain as quite high. And then they did another project, another group, did the postoperative pain project. That was out of the American Pain Society. And they looked at 233 hospitals, and they also did some combination of education and quality improvement. And they found there was some increased use of non-pharmacologic strategies, better pain assessment, but no improvement in patient pain outcomes when they compared them to what they were before. And then Boris Zernikow from Germany somehow convinced all the pediatric oncology centers in Germany to put in a program that had to do with, it was a sort of multi-center quality improvement thing that they had, funded by the German Pediatric Oncology Society, and they looked at their outcomes and they found there was an increase in knowledge but no change in practice. Okay. So, what's that mean? Is this hopeless? What can we really do? Well, I'm going to suggest a couple of things. So obviously, we can create change that is sustainable, I would suggest to you, through some educational initiatives, through some quality, some guideline implementation, through some quality improvement. But I would suggest the thing that's perhaps as critical as anything else is the development of an institutional commitment to pain management. And that is similar to what we now have for confidentiality, what we now have for safety, to have pain be thought of as an essential part of care. So anyway, the implication of all of this, and what people who've written about this have suggested, is that individual initiatives are wonderful. Our postoperative pain work is great. It's often done by one particular caring individual or one group. It doesn't get integrated into the fabric of the institution, into the core values of the institution. And as a result of that, it relies on the good graces of particular people. And often those type of policies don't have staying power necessarily. I like to talk about, we have time, right? I mean, as much time as we need. Okay. Not as much time. 20 minutes is fine. So if anybody's read the book, The Tipping Point by Malcolm Gladwell, there's a very interesting discussion in there about how he describes how they changed some of the criminality that went on in the subways in New York City. And apparently everybody was jumping the turnstile. Everybody was writing on the trains. There was graffiti all over the place. And there were a lot of robbery and holdups were going on the trains themselves. That was perceived as a dangerous place. So some people had the idea that the setting itself attracted that kind of behavior because it seemed to be the context of the environment was such. So what they did was every single night when the trains had graffiti on them, they repainted them. Every single night. They put all their police at the turnstiles because a quarter of people were jumping the turnstiles. And they arrested people and put handcuffs on them if they were jumping the turnstiles. Because they wanted to show that they could, well, anyway, the impact of all of that. And the point was that they wanted to show that this was an environment where that would not be tolerated. Where that context, it was inappropriate to rob. You don't rob people in a place that's well lit, that the trains are nice, and where people aren't jumping over, where there's not a low-grade criminality going on all the time. And they found, again, a significant impact in criminality in the subways. And now I think they're quite safe. You know, not being when somebody lives there and I don't take them, but I can say that. Anyways, but the idea is basically that the context, the environment, is sort of a critical piece. And that's what institutional commitment to pain is about. Mitchell Max, who was a pioneer in a lot of this work, wrote a paper about, is analgesic education enough? And he basically said it's not enough. What we have to do is make pain visible, make it visible throughout the institution. June Dahl, who was the person responsible from the University of Wisconsin Pain and Policy Group, who was the person really responsible for nagging JACO and getting them to insist that pain be a part of institutional reviews. She and Stevenson and a woman named Deb Gordon, there's a number of people from that Wisconsin group who have written a fair amount about this. And they talked about how does one institutionalize pain relief. And they suggested in their work the importance of a kind of interdisciplinary work group that had an administrative mandate to do this. Not just the pain service, but everybody was responsible, and there was an administrative mandate to make that change. It was in the core values, if you will, of the institution. That they set uniform standards for pain assessment, that it didn't change from place to place, that there were explicit policies and procedures, that accountability was defined. Who's responsible for somebody who's still suffering? Who's responsible? The surgeon's not there, the resident's not there, the nurse is not. Who's responsible? That the information was about those policies were readily accessible. They weren't in a book someplace, but they were easily accessible on either a particular drive at the hospital or that they were somewhere that was people could access if they didn't know the appropriate policy and procedure. That patients and families were involved, informed and actively involved in care, that there was routinized education for staff, and that there were ongoing audit processes. So that cluster of things they suggested. So we decided to put some of these things in place, and there have been a couple of institutions that have adapted this, pediatric institute. There have a number of adult institutions that have tried this. Betty Farrell and her group at the City of Hope and a number of places in California, and there have been some other adult institutions. But there have been a number of pediatric facilities that have tried this. We developed something that we called the Ouchless Place. It was probably a mistaken name because it wasn't really ouchless, but at a small hospital where I worked before, and we tried it similarly at the Children's Hospital where I worked subsequently, and we're working on this honestly at Children's Boston now. But BU tried something, Boston Medical, they called pain-free pediatrics. Steve Weissman and his group at the Children's Hospital of Wisconsin developed something they called the comfort zone. And the whole idea was to create an environment in which there was an expectation of at least some consideration of pain relief. We can't relieve everybody's pain. There's some pain that's a necessary part of disease and illness and surgery. But if we demonstrate that we're interested in this, then perhaps we can start to change the context a little bit. So we called it Comfort Central at that hospital, just to give you some of the key elements of it. We had a steering committee with administrative authority and all divisions in the hospital. It wasn't just the anesthesia folks. It wasn't just the pain service. It was all divisions of the hospital were expected to have some presence at those meetings. There were quality assurance expectations made of each of the divisions, if you will, that involved pain. Pain was discussed at the nursing interview. I'm sure it is at your hospital as well. It was discussed at the orientation meetings and Comfort Central. So if you were bringing trays to patients, or you were sweeping the floor, or you were a candy striper, or you were a nurse, or you were an anesthesiologist, at your orientation, there was a 5-minute discussion about the hospital initiative. Okay. There were ongoing educational initiatives. We had a handbook that everybody got. There were brochures, and there was signage all over the hospital that looked something like this, in the elevators and everywhere. And your child has the right to the base pain relief. And we were informing people and hold us to it. And again, we're not promising you morphine, and we're not promising we can do that this will be pain-free, but we're going to do the best that we can. And we like solicit your participation in this process. And we had, a comforter, which was our newsletter. We got permission from Linus Pauling and the group from Universal Features to have the little blanket there. And so we had frequent information about that. This was our advocate. We walk around in these stupid shirts. This was my colleague, Bill Zemsky. And so the idea was to make pain visible. I don't really want to get into this, but basically what we're suggesting here is identify champions, get administrative support for this, the kind of stuff we just talked about. And at the beginning, to start by surveying practice behavior. Where are we right now? Not in a way of castigating people, because we're doing the best we can, but having a baseline to see where we are now. And often I would suggest to you that if the administration would realize that there was a fair amount of dissatisfaction, there would be more support for making some of those sorts of changes. Okay, so how do we get that going? Well, this is the carrot and the stick approaches, and this is sort of a little bit what Dan was talking about before. So there's some stick approaches, which are requirements for accreditation and litigation. There have been a number of lawsuits. There have been some other sort of statutes, some human rights stuff, and then there's the carrot, which is, I'm going to suggest to you, is our little initiative. So what are some of the sort of stick kinds of things? Well, obviously the Joint Commission came around in 2001 and said you had to demonstrate an adequate pain management and a plan for pain management that was necessary for accreditation. And that has had a dramatic impact on at least the documentation of pain. And there's been a whole lot of statutory stuff. In Australia, I happened to be there. There was a large meeting there, and I was there, and the Australian Capital Territory had specific statutes that suggested that patients had the right to receive relief from pain and suffering to the maximum extent that was possible. In California, there was a pain summit a number of years ago, and they came up with a number of things, such as doctors who refuse, who don't want to give opioids, have to give patients a referral to someone who might be willing to do that. There was mandatory physician education. There was a mechanism for following up complaints of undertreatment. So there were a number of sort of statutory things that they put in place. And there's also this kind of rights-based approach that, again, Dan alluded to. I don't think it's going to exactly have a dramatic impact. No one's going to run to the UN if you don't give them opioid. But as part of setting the concept, the context for this, there have been a number of meetings of folks who are starting to think about pain relief as a human rights issue. Dan wrote an exquisitely lovely article on that with Michael Cousins that was very eloquent and described from the UN's perspective what specific statutes made sense to invoke to suggest that people weren't getting adequate pain relief. That really applies mostly, I would suggest, to countries that had denied people opioid access, and there are many of them. But it can be used for other purposes as well. From pediatrics, there's a whole UN Convention on the Rights of the Child. I don't know if anybody's familiar with that. We're one of the 2 countries in the world that are not signatories to that. Us and Somalia, which doesn't have a government. But that being said, there are a number of statutes of the UN Convention on the Rights of the Child that might have relevance to this. There's a non-discrimination, and people have used that as illness discrimination, so people with certain illnesses are entitled to pain relief. There's the best interests of the child statute. There's a right to development and survival, and we talked a little bit before about the impact of pain on development. And then there's what they call the right to be listened to, the right to be listened to. Okay. So finally, as the final sort of thing, what is the carrot? I'm going to suggest to you at least one carrot might be the program that we're now in the phase of, in a very active phase of developing and which will be ready to roll within a month or so. And that is called the Child Kind Initiative. And what we've decided to do was to develop a sort of internationally sanctioned award to healthcare institutions that put in place the types of things that I spoke about. Have policies and protocols in place, an institutional commitment to pain as evidenced by administrative support, have ongoing educational initiatives, have audits that are done on a regular basis. And what we've developed to do that is we've solicited from hospitals around the world their policies and protocols, their audit processes, a whole bunch of other things, and we're developing a clearinghouse and repository for that information for institutions if they want to do that. Anyway, if they put in place those sorts of things, we will then accredit them, if you will, as a child kind institution. And it's based on the Baby Friendly Initiative. Anybody familiar with that? Okay. So Baby Friendly is a wonderful, very creative thing developed by WHO and UNICEF. And what they did was they decided to award in a similar way with a big fancy award in the lobby of your hospital that says you are a privileged, an institution that has gone far and beyond that state of the art in the area of breastfeeding. Because at that time a lot of hospitals were giving out formula. They were, especially in developing countries, people would water down the formula, and it seemed to be a discouragement of breastfeeding. So they decided to make this seemingly a state-of-the-art thing. And so there are now 15,000 baby-friendly hospitals, 1,000 in the U.S. I think BMC is the only one in this community. And they have been ongoing for all these number of years, and their number of papers have showed how they dramatically impacted on breastfeeding behavior. Okay, so we decided to steal that and use a similar model. And so we were fortunate to get a number of organizations to endorse this. World Federation of Societies of Anesthesia, a number of Child Life Council, a number of the nursing societies, some of the palliative care societies. There have been some other organizations as well. We had a big meeting in Bellagio, Italy, not too bad, where we sort of brought people from a number of different countries together, developed our core principles, and are looking forward to sort of launching this at the International Forum on Pediatric Pain, which is coming in 2 weeks. And the child kind accreditation criteria are the ones that sort of I've suggested to you already. So in summary, we've made enormous progress in both research and the clinical aspects of pediatric pain, but there remain gaps in our knowledge and in particular in the implementation of what we presently know. And there are a number of strategies that can be put in place to do this. Education, guidelines, audits are all wonderful, but they're more likely to be successful if they're part of an overall comprehensive institutional commitment to pain relief. Thank you very much.
Well, thank you very much, Neil. I mean, we're so privileged that you came here. I mean, we're delighted that people can see cutting edge, but you're seeing actually something just before the cutting edge is applied. And Neil is uniquely qualified to have given a tremendous context for this, ranging over the last 25 years, much of which he has contributed to. And in the interest of time, I didn't go into all the, let's just say that if you want to learn about pain in infants, children, and adolescents, you want to get the standard text, you will get the text that Neil is the senior author of. I think this is Chuck Birdie and Myron Yasser.
Yeah.
Yes, but if you just look up Neil Schecter, pediatric pain, you'll see that you've been listening to someone who is absolutely definitive and is shaping global health policy, and that's tremendous. So, are there questions? I actually see students and graduates from our program in the audience. There's a bunch of them. And we're really happy that you're all here taking time out of your busy days. So are there any questions for Professor Schecter? No questions. Iqbal.
So you presented some evidence of somewhat discouraging that education along with quality improvement efforts do not really result in long-term improvement. What's the evidence that and institutional commitment that it actually significantly improves the outcome?
Just repeat the question.
Yes. So the question was, the suggestion was that a number of these initiatives that people have tried, educational initiatives, and as well as audits and other sorts of things, are less than ideal. What's the evidence that institutional commitment to pain sort of will move it that much further? Very limited evidence. Very limited evidence. There's only a few institutions that are doing this. They're starting to publish some of their work right now. It's all on the adult side. There's nothing on the pediatric side at this juncture. It's all intuitive that we're doing that. But it may well be that this doesn't change practice that much either. But I think it's bringing it that much further. Putting it as a core value of an institution, putting it in the, because the children's were trying to put it into the core values of the institution. We do hope that it will change practice, because that's what changed practice around safety, and that's what changed practice around confidentiality. Those changes did occur, and this is sort of the type of thing that did it, that administrative commitment. So we're extrapolating with the hope that that will have a similar change. But again, we don't know for sure. But that's a very good question. And I hope I'll come back here in 5 years and tell you that it does or doesn't.
One more question, Dr. Stratford, and then any other further questions maybe people can come up.
You know, I really love the idea of child kind. And I mean, I always say to Neil, I wanted to write an article called Politics of Pain Service, because it does speak to the issues about how things become successful and not successful. Do you think we have models in medicine in which this kind of approach has worked, really worked? And the one that came to mind for me was the whole idea of childbirth in this country, which was, when I was in medical school, I remember the first, childbirth I saw, they were combining at the time two different things, which was the husband could be in the delivery room, but they still gave the mother scopolamine. So the mother was hysterical and crazy, and the husband was there, and we eventually evolved, but we had a model that really changed childbirth in this country. And I think it segued into developments in other areas, like the stuff that was going on in Case Western about parental involvement with the newborn. It was happening, and that right now, maybe it's the perfect storm for that as well. And just, what other models do we have that have worked?
Well, we don't. That's a very good point. I think a lot of what changed childbirth practice was advocacy. Yeah, was consumer advocacy, because that really, people said, I'm not going to that, and people were having an increasingly educated populace who are demanding better care or a different type of care. I'll just tell you an anecdote that we had just to give you a sense of the power of what empowers parents. So we, again, a very long time ago, decided I had a medical student slave labor, and we decided to study something over a summer. And at that point, again, for laceration repair, it was not uncommon for parents to be exiled from the room. And the parents were just sent out and whatever. So we decided to look at the impact of parental presence on pain response in kids. So we had a natural study to do. So we randomized families to parental presence, parental absence, or parental presence with a role, with a job, teaching them a 2-minute teaching about blowing bubbles or distraction or a book to read or something like that. So I had 2 or 3 medical students working with me, and they were hanging out in the emergency department. And each week we'd go and review the number of cases that were enrolled in this, and nothing was enrolled. Nobody enrolled in our study. And I said, what the hell's going on? We have 1,000, were there no? He says, no, we had 150 lacerations. And it turned out that when we did the informed consent and told parents that they didn't have to be, that they might be exiled, but it was possible if they asked that they could be with their child, no one wanted to enroll in the study. So it was a lesson to me in the power of those ideas and parents' desires to do that kind of stuff. So I do think with sort of advocacy, raising the bar, making people more aware, making pain visible, that we can make that sort of change. And I do think the childbirth model is another one. Well, before you came in, Maureen, I mentioned the Sonny's study and how that changed anesthesia practice in a very short period of time with multiple editorials coming out around it. So I think some ideas can float and change, and I think hopefully this will be one of them.
Well, I know that we could ask a lot more questions and go on and on. I think Neil will be gracious enough to stay here for a few minutes up front We've got to get this huge crowd that has come, which you can't all see on the video because it's around, just standing room only, it's just unbelievable. They can come up and hear Neil. We've got to get people back to their days. Thank you very, very much for coming and giving a definitive talk.